Welcome to ECA ICA Anastomosis, External to Internal Carotid Artery Anastomotic Connections, a comprehensive educational course originally presented at RSNA 2000. This program was developed to address a critical gap in interventional neuroradiology training, the identification of dangerous collateral pathways that can turn a routine embolization procedure into a catastrophic event. Over the next 85 slides, we will cover 78 distinct topics supported by over 117 angiographic images. The course is organized into 6 sections: basic anatomy, ECA ICA Anastomosis, normal variants, angiographic techniques, case studies, and post-operative bypass graphs. By the end, you should be able to recognize and map all major ECA ICA anastomotic pathways before undertaking any intracranial interventional procedure. This slide summarizes the academic purpose of the course. The core clinical problem is straightforward, as intracranial interventions, embolization, stenting, aneurysm coiling, and tumor devascularization have become standard of care. The risk of inadvertent stroke or blindness from unrecognized collateral pathways has grown proportionally. The 3 learning goals define what a competent interventionalist must be able to do. First, map all potential collateral connections between the external and internal circulations. Second, recognize normal anatomic variants that alter expected vascular patterns. And third, apply specific angiographic techniques that make these pathways visible before intervention. This is not theoretical knowledge, it is a patient safety imperative. The foundational references for this course represent the essential literature of cerebrovascular anatomy and neuroangiography. Newton and Potts remains the gold standard anatomic atlas. Morris's practical neuroangiography provides the procedural context. Osborne's diagnostic cerebral angiography is the definitive clinical reference. Lasionius and Berenstein's surgical neuroangiography defines the embryologic and functional anatomy that underlies the anastomotic connections we will study. Krayenbuhl and Yasargil provide the historical foundation. The authors acknowledge the generosity of colleagues who donated cases, particularly the reviewers who verified the clinical accuracy of each example. These cases represent real patients whose angiograms teach us how to protect future patients. Section 1 covers the foundation that makes everything else meaningful: normal cerebrovascular anatomy as seen on angiography. You cannot identify an abnormal collateral, a dangerous anastomosis, or a clinically significant variant unless you first know exactly what normal looks like. This section systematically reviews the external carotid artery with all its branches, the common carotid in AP and lateral projections through all phases, the vertebral circulation in AP and lateral views, the posterior inferior cerebellar artery in detail, and the normal deep venous anatomy. Invest time in this section. It is the reference framework against which all pathological patterns are measured. This overview slide maps the 7 anatomic series that follow. Normal external carotid angiography is presented first because the ECA is the source of most dangerous collateral pathways. Knowing its branches intimately is prerequisite knowledge. The common carotid AP and lateral series are presented with meticulous landmark labeling because positioning quality directly determines diagnostic value. The vertebral series in AP and lateral views covers the entire posterior fossa vascular tree. The PICA series provides the detailed segmental anatomy needed to interpret posterior fossa pathology. Finally, the subependymal venous anatomy teaches the reader to use veins as positional landmarks for mass effect and shift. Each series will be presented across multiple slides to allow full image quality at each phase. This first external carotid angiogram is from a patient with ICA occlusion at the origin, a situation that maximally opacifies the ECA and makes every branch visible. Study the numbered labels carefully. Key branches to fix in memory: the superior thyroid artery, 3, is the first anterior branch and a common landmark. The lingual, 5, and facial, 6 arteries are the next 2. The ascending pharyngeal, 8, is the critical posterior branch supplying the skull base. The occipital artery, 9, provides the C2 muscular anastomosis to the vertebral. The internal maxillary, 10, is the largest terminal branch and the most dangerous anastomotic source. And the superficial temporal, 11, terminates as the sty used in bypass surgery. Note that branch 6A traces the facial artery wrapping around the mandible, a key landmark on lateral views. This second lateral ECA angiogram reinforces branch identification with a different patient and projection angle. Compare this image with the first series. Note how the relative positions and calibers of branches can vary between individuals while the branching pattern remains consistent. The sternocleidomastoid branch of the occipital artery, 4, is an important landmark because it parallels the sternocleidomastoid muscle and is reliably visible. The internal maxillary artery, 10, is the dominant terminal branch. In patients with ICA occlusion, it becomes massively enlarged as it recruits ophthalmic artery territory. Practice identifying each numbered branch on these images before proceeding, as they will appear repeatedly in the anastomosis sections. This third ECA angiogram focuses specifically on the branches of the internal maxillary artery, the vessel responsible for most dangerous ECA ICA anastomosis. The middle meningeal artery, 9, with its frontal, 9A, and squamous, 9B branches, is the most critical. It anastomosis with the ophthalmic artery via its lacrimal branch. The anterior deep temporal artery, 19, runs in the groove of the greater sphenoid wing and connects to the ophthalmic via an orbital branch. The infraorbital artery, 17, traverses the inferior orbital fissure and connects to palpebral and ophthalmic branches. The sphenopalatine arteries, 18, supply the nasal mucosa and can provide ethmoid ophthalmic connections. Every branch labeled here has a documented ECA ICA anastomotic pathway. This is why the internal maxillary is the most important vessel to evaluate before any ECA embolization. Slide 4 of the ECA series highlights the most clinically dangerous distal anastomotic connections. The orbital branch of the infraorbital artery, 20, is particularly significant. It passes through the inferior orbital fissure and can communicate directly with the ophthalmic artery, creating a pathway by which internal maxillary artery injection can cause ophthalmic occlusion and blindness. The angular branch of the facial artery, 21, is the terminal branch that anastomoses with the dorsal nasal branch of the ophthalmic, the basis of the facial ICA collateral pathway. These distal connections are often very fine caliber on normal angiograms and may only become visible with the enhanced injection techniques described in section 4. Always interrogate the orbital and periorbital territory on pre-embolization ECA angiography. This fifth and final ECA lateral view provides the complete summary image that ties together all branch anatomy. Note the greater palatine, 11, and sphenopalatine, 12, arteries arising as terminal branches of the internal maxillary. These are important during nasal and sinus tumor embolization because their terminal branches can communicate with ophthalmic artery territory via ethmoidal connections. The occipital artery, 9, and middle meningeal, 10, are again clearly visible. Use this image as a reference card. Before any ECA procedure, mentally trace each numbered branch and ask whether it has a known anastomosis with the ICA territory. If the answer is yes for the vessel you are targeting, advanced angiographic techniques and super-selective catheterization are mandatory. This lateral rollover image provides a composite view that is particularly useful for understanding the spatial relationships of ECA branches in the lateral projection. The rollover effect highlights the transition from ECA to ICA territory. 4 critical anastomotic connections are optimally seen on lateral ECA angiography: the middle meningeal to ophthalmic via the lacrimal branch, the anterior deep temporal to ophthalmic via its orbital branch, the facial angular to ophthalmic via the dorsal nasal root, and the ascending pharyngeal to ICA via the neuromeningeal trunk. Always obtain a lateral view during selective ECA injection. The AP view alone will miss many of these connections because vessels overlap in the anteroposterior plane. The normal common carotid AP series consists of 4 temporal phases shown here: early arterial, late arterial, capillary, and venous. On the AP view, the key positioning criterion is superimposition of the orbital roof on the top of the petrous pyramid. This alignment ensures the image captures both the supraclinoid ICA and the cavernous sinus without excessive magnification distortion. Study all 4 phases. The arterial phase shows vessel caliber and branching patterns. The capillary phase reveals the cortical and deep gray matter blush that confirms normal perfusion distribution. The venous phase shows both superficial cortical and deep central veins. Absence of any phase or territory in the expected location indicates either stenosis, occlusion, or collateral shunting. This landmark labeled AP carotid image is the anatomic reference for the entire anterior circulation. ICA segments 1, 4 must be mentally superimposed on every AP carotid angiogram you interpret. The lenticulostriate group of arteries, MCA branch group 2, are key indicators of mass effect. Lateral displacement indicates a midline mass. Inferior displacement suggests a subdural collection. The Sylvian point, MCA branch group 7, should be between 40 to 45 mm from the inner table. A more medial position suggests a subdural hematoma. The measurement technique for midline shift uses the halfway distance between the orbital rami of the frontal bone anteriorly and the inner table parietal tables posteriorly. The recurrent artery of Hoebner, 12, will be discussed in detail in the normal variant section. The normal common carotid lateral series shows 4 temporal phases. The lateral projection is obtained with superimposition of the mandibular rami. When both rami are perfectly overlapping, the ICA anatomy is displayed without rotational distortion. This projection is superior to AP for visualizing the ICA segments, the ophthalmic artery origin, the posterior communicating artery, and the temporal lobe branches of the MCA. Note how the capillary phase shows the choroid blush posteriorly, choroid plexus of the temporal horn, as a distinct opacity separate from the basal ganglia thalamus blush. These blushes are reliable landmarks for locating deep structures on the lateral view. The anatomic labeling on this lateral carotid image shows the complete ICA course from cervical 1 through petrous 4, cavernous 5, and supraclinoid 6 segments. Key branches. The ophthalmic artery 7 should be the first branch after the ICA emerges from the cavernous sinus. The posterior communicating artery PCOM 8 connects to the posterior cerebral artery. The anterior choroidal artery 9 supplies the choroid plexus, hippocampus, and internal capsule. It is one of the most dangerous vessels to inadvertently embolize. The choroid blush, 7 in capillary phase, is the posterior globe choroidal circulation. It appears as a crescent-shaped opacity in the posterior orbit on the lateral view and is a reliable marker of ophthalmic artery patency. The normal vertebral angiography AP series in Townes projection covers 4 phases. The Townes projection positions the posterior margin of the foramen magnum at the top of the image, the posterior clinoid and dorsum celli in the midfield, and the posterior fossa in the primary area of interest. The transverse sinuses mark the boundary between the posterior fossa and the supratentorial region. Structures above this line during vertebral injection represent posterior cerebral artery branches, not cerebellar vessels. The AP vertebral view is essential for identifying bilateral PICA, bilateral AICA, and bilateral SCA origins. Asymmetry between sides is immediately apparent on this projection. These anatomic landmarks on the AP vertebral image are the reference framework for posterior fossa angiography. The clivus surface 6 serves as a positioning guide. The projection should be parallel to this surface to minimize distortion. Vessels, basilar 5, should course in the midline. Any lateral deviation suggests tortuous basilar. See normal variants. Pica origin 6 should be bilateral and symmetric. Asymmetric or absent pica fills indicate hypoplastic or isolated pica variant. The calcarine 10 and parieto-occipital 11 PCA branches should extend to the inner table. Failure to reach the inner table suggests posterior fossa mass effect or hemispherectomy territory. Venous phase, the petrosal sinuses 4 and transverse sinuses 11 provide important landmarks for posterior fossa mass localization. The normal vertebral lateral series through 4 phases is the essential view for posterior fossa anatomy. The lateral projection is centered just inferior to the calcified pineal gland. The pineal is the perfect midpoint landmark for posterior fossa centering. The anterior portion of the skull is routinely coned off because the primary area of interest is posterior. Both vertebral arteries fill on this view. The smaller contralateral vertebral fills by reflux. and their meeting at the pontomedullary junction forms the basilar artery. The cerebellar hemispheric branches should extend uniformly to the tentorium superiorly and the foramen magnum inferiorly. Any focal absence of filling indicates either mass effect or occlusion. The lateral vertebral landmark image is the definitive reference for pica segmental anatomy. Knowledge critical for posterior fossa intervention. Pica segments A through F track the posterior inferior cerebellar artery from its origin at the intradural vertebral through the choroidal point to the vermian branches. The choroidal point D marks the apex of the tonsillar loop. Its position relative to the foramen magnum indicates tonsillar herniation when displaced below the foramen magnum. Deep perforators from the posterior communicating artery 4 and posterior cerebral artery 5-6 are visible on the lateral vertebral view in patients with large PCOM. These supply the thalamus and cannot be sacrificed. The basilar vein of Rosenthal 5 on the venous face traces along the tentorial edge and joins the great vein of Galen. This detailed pica anatomy slide is one of the most important reference images in the course. The 13 numbered structures trace the complete pica course from the cervical vertebral artery to the posterior cerebellar hemispheric branches. Clinically, the most important segment is the lateral medullary 7. The pica origin from the vertebral artery in this location means that vertebral artery interventions at the pica origin can cause lateral medullary syndrome, Wallenberg syndrome, if pica flow is interrupted. The choroidal branches 10 supply the choroid plexus of the fourth ventricle. Enlarged choroidal branches on a vertebral injection suggest an ependymoma or choroid plexus tumor. The inferior vermian branch 12 is the largest and most consistent branch and the one best seen on epivertebral angiography. The subependymal venous anatomy is the foundation for using venous landmarks in mass localization. The 14 numbered veins map the entire surface of the lateral ventricle. Connecting the tips of all these veins outlines the lateral ventricular margin on angiography. This technique allows estimation of ventricular size without CT or MRI, using only the angiogram, particularly useful in the pre-CT era in which this course was originally developed. The venous angle 13, the junction of the thalamostriate vein and internal cerebral vein, is the most reliable landmark for the posterior margin of the foramen of Monro and the anterior thalamic surface. Lateral displacement of the internal cerebral vein 14 indicates contralateral mass effect. Vertical displacement suggests supratentorial herniation. The posterior communicating artery is the critical intracranial connection between the anterior carotid and posterior vertebrobasilar circulations. In this slide, the right PCOM 2 and left PCOM 3 are clearly visualized connecting the supraclinoid ICA to the mesencephalic PCA. 1. A large PCOM, the so-called fetal configuration when it is the dominant supply to the PCA, dramatically changes the risk profile of carotid territory procedures. ICA PCOM junction aneurysms are among the most common intracranial aneurysms and often require pre-treatment assessment of PCOM size. When the PCOM is large enough to sustain the posterior circulation, carotid balloon test occlusion and provocative testing become essential before any planned ICA sacrifice. Section 2 is the clinical heart of this course, the direct documentation of every known anastomotic pathway between the external carotid artery and the internal carotid circulation. These are not theoretical connections. They are pathways visible on angiography that have caused documented cases of blindness, stroke, and death during otherwise well-planned embolization procedures. The section covers 8 major groups: internal maxillary artery connections, the largest group, ascending pharyngeal roots, facial artery anastomosis, occipital vertebral pathways, posterior auricular connections, superficial temporal roots, postoperative bypass grafts, and extracranial subclavian vertebral pathways. Each group will be covered with angiographic images demonstrating the actual collateral in action. This overview slide is your pre-procedural checklist. Before any ECA or ICA embolization, run through each of these 8 pathways and ask, is the target vessel a contributor to this route? For internal maxillary artery procedures, check MMA ophthalmic via lacrimal, atto ophthalmic via orbital branch, infraorbital ophthalmic via inferior orbital fissure, foramen rotundum to inferolateral trunk, and Vidian to petrous ICA. For ascending pharyngeal procedures, check neuromeningeal trunk to cavernous ICA and inferior tympanic to carotico-tympanic ICA. For facial artery procedures, check angular dorsal nasal ophthalmic. For occipital artery procedures, check C2 muscular to vertebral. The extracranial roots become critical in multi-vessel occlusive disease. Subclavian angiography may be necessary to complete the map. The internal maxillary artery is the single most important ECA branch for anastomotic risk. Its terminal branches extend through multiple skull base foramina and create connections at every level, from the petrous ICA to the ophthalmic artery. The clinical hierarchy of danger is MMA lacrimal ophthalmic is the most commonly encountered dangerous pathway. Arter ophthalmic is the second most common. Infraorbital ophthalmic and foramen rotundum inferolateral trunk are less common but well documented. Vidian artery to petrous ICA is rare but has been reported in JNA and other skull-based tumors. Before any internal maxillary artery embolization for meningioma, JNA, epistaxis or dural AVF, every one of these connections must be ruled out with super-selective angiography and provocative testing. This angiogram is the classic demonstration of the MMA, lacrimal ophthalmic anastomosis, the most clinically important ECA ICA connection in neurointervention. The lacrimal branch of the MMA extends anteriorly through the superior orbital fissure to anastomose with the ophthalmic artery. In this case, the ophthalmic artery is also receiving supply from the anterior deep temporal artery, a dual anastomotic supply to the ophthalmic from two separate MMA territory branches. The clinical implication is direct. Liquid embolic agents, particles or coils placed in the proximal MMA can reflux or migrate through this connection into the ophthalmic artery, causing central retinal artery occlusion and permanent blindness. This connection must be evaluated on every lateral ECA angiogram before meningioma or dural AVF embolization. This case of ICA occlusion with cavernous ICA reconstitution via the ophthalmic artery demonstrates the ADTA pathway in action. The internal maxillary artery sends its anterior deep temporal branch through the sphenoid groove into the orbit, where it contributes blood flow to the ophthalmic artery. This retrograde ophthalmic flow then reconstitutes the cavernous ICA, a striking demonstration that the ophthalmic artery is bidirectional when ICA flow is absent. Note the dual supply. Both ATA and MMA lacrimal are feeding the ophthalmic simultaneously. This pattern of dual ECA branches converging on the ophthalmic artery is common when the ICA is occluded, because the hemodynamic demand of the ophthalmic territory recruits every available ECA connection. This slide shows the ADTA anastomosis from two projections, lateral and AP, which is the gold standard approach for any anastomotic pathway before embolization. The lateral view shows the characteristic curve of the ADTA where it follows the groove of the greater wing of the sphenoid. This curve is the anatomic landmark that identifies the ATA among the internal maxillary branches. The AP external carotid view confirms retrograde ophthalmic artery filling via ATA. The ophthalmic artery is visible coursing medially from its orbital origin to reconstitute the cavernous ICA. Always obtain both projections when evaluating internal maxillary territory. The AP view confirms what the lateral suggests, and vice versa. The infraorbital artery anastomosis is less well known than the MMA lacrimal connection, but equally dangerous. The infraorbital artery, a branch of the internal maxillary, enters the orbit through the inferior orbital fissure and sends muscular, palpebral, and naso-orbital branches that anastomose with the ophthalmic artery. In this angiogram, the unmarked arrows represent muscular collaterals traversing the inferior orbital fissure. This route is particularly relevant during embolization of sphenopalatine artery targets for epistaxis, because the infraorbital artery arises from the same pterygomaxillary segment. Provocative testing with short-acting anesthetics before particle embolization of any internal maxillary branch is essential when this connection is identified. The artery of the foramen rotundum is a deep branch of the third portion of the internal maxillary artery that courses posteriorly through the foramen rotundum or the superior orbital fissure to anastomose with the inferolateral trunk of the cavernous ICA. In this case, the ICA is occluded near the origin, and the foramen rotundum artery is the primary reconstitution pathway. The middle meningeal artery also contributes retrograde ophthalmic flow via its recurrent meningeal branch. This layered anastomosis with multiple ECA branches converging on both the cavernous ICA and the ophthalmic artery simultaneously is typical of chronic ICA occlusion, where collateral flow develops along every available pathway to meet the hemodynamic demand of the brain. This case is a 52-year-old male with left MCA infarction and grand mal seizures caused by ICA occlusion. The angiogram reveals reconstitution of the subclinoid ICA via two separate deep internal maxillary branches, both likely traversing foramen rotundum and the inferior superior orbital fissure. The early image is diagnostically important. It shows the subclinoid ICA opacifying before retrograde ophthalmic flow appears. This temporal sequence proves that the direct foramen rotundum route is faster than the ophthalmic route, confirming it as the primary collateral. This case illustrates the teaching principle. When ICA reconstitution is visible at the petrous cavernous junction with no visible ophthalmic filling, always look for a deep internal maxillary branch traversing a skull base foramen. The Vidian artery, also called the artery of the pterygoid canal, is the most direct anatomic connection between the petrous ICA anteriorly and the internal maxillary artery posteriorly. It runs through the pterygoid canal in the sphenoid bone. This case of juvenile nasopharyngeal angiofibroma, JNA, provides an unusually clear demonstration because the enlarged Vidian artery supplies the tumor mass, making it clearly visible. The lateral ICA shows the Vidian artery originating from the petrous ICA and entering the tumor. The lateral ECA shows MMA ophthalmic connection. The AP ICA shows the enlarged Vidian artery coursing through the pterygoid canal. JNA is the classic setting for Vidian artery demonstration because these tumors reliably recruit supply from both ICA and ECA, making the pterygoid canal connections visible that are too small to see in normal patients. Vidian artery case 2 demonstrates a clinically crucial diagnostic principle. The level of ICA reconstitution localizes the collateral route. This patient has ICA occlusion at the carotid bulb. The ICA is reconstituted at the petrous portion, not at the cavernous sinus, not at the ophthalmic. Critically, there are no ophthalmic artery collaterals visible. The petrous level reconstitution with absent ophthalmic collaterals is the imaging fingerprint of the Vidian artery pathway. The internal maxillary artery feeds the Vidian artery, which enters the petrous ICA through the carotid canal just above the foramen lacerum. This case teaches that you cannot rely solely on ophthalmic artery retrograde flow to explain ICA reconstitution. Always check the level of reconstitution and correlate with skull base anatomy. The ascending pharyngeal artery is the most complex ECA branch from an anastomotic standpoint because it has connections at multiple levels along the ICA. The cavernous ICA via the meningohypophyseal trunk, the petrous ICA via the inferior tympanic caroticotympanic connection, and the vertebral artery via the neuromeningeal trunk. Two clinical pearls deserve emphasis. First, the ascending pharyngeal can mimic the string sign of an occluded internal carotid artery when it is massively enlarged. This has led to cases of unnecessary surgery on patients who actually had viable ICAs reconstituted by the ascending pharyngeal. Second, the classic symptom of burning sensation in the posterior throat during vertebral angiography indicates reflux of contrast into the ascending pharyngeal territory, a reliable functional test of its patency. This case of right CCA occlusion demonstrates the ascending pharyngeal artery acting as the sole reconstitution pathway for the cavernous ICA via the meningohypophyseal trunk. The right CCA is occluded. The ascending pharyngeal, arising from the ECA, sends its neuromeningeal trunk through the jugular foramen to anastomose with the meningohypophyseal trunk of the cavernous ICA. Simultaneously, vertebral to occipital artery retrograde flow is filling the external carotid retrograde. This combined pattern, ascending pharyngeal from below and occipital from behind, simultaneously filling the ECA, is the hallmark of proximal CCA occlusion with competent circle of Willis collateral demand. Before any procedure on the ascending pharyngeal artery, this entire multivessel collateral network must be mapped. The inferior tympanic caroticotympanic anastomosis is a tympanic bone pathway that most radiologists have never consciously recognized on an angiogram. The ascending pharyngeal artery sends its inferior tympanic branch into the tympanic cavity, where it anastomoses with the caroticotympanic artery, a small branch arising from the petrous ICA within the carotid canal. In this case, ICA occlusion at origin is reconstituted at the petrous portion via this tympanic bone connection. Additionally, the ophthalmic artery is filled retrograde from the ADTA and stay frontal branch. This case illustrates the principle of parallel collateral recruitment. When ICA flow is absent, the brain simultaneously recruits every available collateral pathway, tympanic, ophthalmic, and stay, to compensate for the lost flow. The Vesalianum route, named after the foramen Vesalianum through which collateral vessels pass, is demonstrated here with 3 AP views tracking the collateral pathway from origin to destination. Case 1 shows left ICA bifurcation occlusion with an enlarged ascending pharyngeal artery that sends numerous branches through the medial anterior middle cranial fossa, probably via foramen rotundum or foramen Vesalianum, to reconstitute the petrous ICA. 3 key observations. First, no ophthalmic retrograde filling. This route bypasses the ophthalmic territory entirely. Second, meningeal vessels fill early with some anteriorly displaced meningeal branches, suggesting collateral competition. Third, the ICA is reconstituted at the petrous portion, not the cavernous. The level of reconstitution is a critical diagnostic discriminator between different anastomotic routes. The posterior pituitary gland has a dual blood supply. The ICA inferior hypophyseal arteries supply the neurohypophysis, posterior pituitary, under normal conditions. When the ICA is occluded, the clival branches of the hypoglossal division of the neuromeningeal trunk from the ascending pharyngeal artery can take over this supply, as demonstrated in this angiogram, where the posterior pituitary is opacified from the ascending pharyngeal artery territory. The clinical significance extends beyond an anatomic curiosity. Ascending pharyngeal artery embolization for jugular foramen tumors or dural AVFs carries the risk of posterior pituitary ischemia if the clival branches are sacrificed. Diabetes insipidus has been reported as a complication of ascending pharyngeal embolization when this supply is not preserved. The facial artery anastomosis is the simplest ECA ITA connection conceptually, but practically important during epistaxis embolization. The angular artery, the terminal branch of the facial artery, traverses the nasal bridge and anastomosis with the dorsal nasal branch of the ophthalmic artery at the medial canthus. In this RIO projection, the angular artery is clearly visible, connecting the facial artery territory with the ophthalmic territory. The scout image confirms the facial artery course along the mandible before curving up to the nasal bridge. During embolization of the facial artery for epistaxis or facial hemangiomas, particles must not be advanced distal to the point where the anastomosis with the ophthalmic begins. Provocative lidocaine testing before embolization is recommended when this connection is identified. The occipital vertebral anastomosis at C2 is the most important extracranial collateral for the posterior circulation. Understanding the bidirectionality of this connection is critical. Normally, the occipital artery flows outward from the ECA. In vertebral artery stenosis or occlusion, the flow reverses and the occipital artery fills the vertebral artery retrograde. The multi-level consequence is profound. Occipital ECA, internal maxillary, ophthalmic, ICA can reconstitute the intracranial ICA from the vertebral via a completely extracranial chain. The warning about confusion with the hypoglossal artery is practically important. Both vessels enter the skull through foramina near the C2 level on AP angiography. The key difference is that the C2 muscular branch is extradural, while the hypoglossal artery is intradural and traverses the hypoglossal canal. This case demonstrates the full 5-vessel chain from vertebral artery to intracranial ICA via the ECA, the most complex collateral pathway in the cerebrovascular system. Step 1. Left vertebral artery sends an enlarged C2 muscular branch to the occipital artery. Step 2. Occipital artery fills the external carotid retrograde. Step 3. ECA fills the internal maxillary artery. Step 4. Internal maxillary fills the ophthalmic artery. Step 5. Ophthalmic artery reconstitutes the cavernous ICA. The early to late temporal sequence demonstrates how the contrast front advances through this relay chain, opacifying each successive vessel in turn. The AP view note about confusion with the hypoglossal artery is clinically important. Always trace the vessel from its origin in the muscular branches to its connection point to confirm it is extradural and not hypoglossal. A C2 case 2 provides a more focused demonstration of the C2 muscular occipital anastomosis with the coned view, a technique of limiting the X-ray beam to the area of interest that dramatically improves image detail in the cervical region. The nearly occluded left CCA creates the hemodynamic conditions for this collateral to be visible. With reduced ICA pressure on the contralateral side, the vertebral artery shunts blood through the C2 muscular branch to the occipital and from there retrograde into the ECA. The coned view is a practical reminder that angiographic technique matters. Without coning, the C2 muscular branches are lost in scatter and noise from the surrounding neck soft tissues. Always cone down on areas of interest before concluding that a collateral is absent. The bilateral anomalous occipital artery origin from the proximal ICA is a rare variant that represents a dramatic management challenge. If unrecognized, any procedure on the proximal ICA, stenting for stenosis, coiling of a near bifurcation aneurysm, balloon occlusion testing, could simultaneously devascularize the occipital territory bilaterally. The three-view documentation is the correct approach. Lateral right CCA, lateral left CCA, and oblique left CCA confirm the anomalous origin from multiple angles. The oblique view is particularly useful here because it separates the ICA from the ECA at the bifurcation, allowing clearer visualization of the occipital artery arising from the posterior ICA wall rather than the anterior ECA. This case underscores the need for bilateral carotid angiography with careful evaluation of all branch origins before any proximal ICA intervention. The posterior auricular artery is often overlooked in discussions of ECA ICA anastomosis, but it has two documented connection pathways. The stylomastoid branch anastomosis with the petromastoid branch of the anterior tympanic artery, itself a branch of the ICA, through the mastoid foramen and petromastoid canal. Additionally, the persistent stapedial artery variant, covered in the normal variance section, links the ICA to the MMA via the middle ear, and the posterior auricular territory is part of this embryologic connection. Clinically, the posterior auricular artery is most important during embolization of dural arteriovenous fistulas in the transverse and sigmoid sinuses, where it is frequently a major arterial feeder. Preoperative evaluation must include selective posterior auricular injection in posterior fossa dural AVF cases. The superficial temporal artery is unique among ECA branches because it has both a natural anastomotic connection to the ophthalmic artery and forms the basis of the most common surgical bypass procedure for ICA occlusion. The supraorbital branch of the stay traverses the supraorbital notch, a bony channel that can be palpated on physical examination, and connects with the supraorbital branch of the ophthalmic artery. In ICA occlusion, this connection provides retrograde ophthalmic flow, as demonstrated here in 3 projections. Clinically critical, the stay must never be sacrificed in a patient who has undergone stay MCA bypass surgery, as shown in the encephalodurosynangiosis case later in this section. Even in patients without a formal bypass, the stay may be providing critical collateral ophthalmic flow and must be preserved. Extracranial circulation collaterals, the subclavian and cervical routes to the vertebral artery, are the final tier of the cerebrovascular collateral hierarchy and are often the only remaining blood supply in patients with multivessel occlusive disease. These routes are invisible unless specifically sought with subclavian angiography. Carotid and vertebral injections alone will not demonstrate them. The key anatomic principle is the relationship between the ascending cervical, anterior, and deep cervical, posterior arteries on lateral view. When both are enlarged as vertebral collaterals, the lateral projection clearly separates them. The anterior spinal artery route is the most indirect, thyrocervical trunk to anterior spinal artery to basilar, bypassing the vertebral artery entirely. This route is only detectable if the lateral posterior fossa view is obtained during subclavian injection. This dramatically complex case demonstrates a patient with right CCA occlusion, bilateral vertebral occlusions, and 80% left ICA stenosis, essentially living on a single critically stenotic vessel. The aortic arch injection reveals the ascending and deep cervical arteries as the primary blood supply to the right cerebral hemisphere via the vertebral reconstitution route. The RPO projection optimally demonstrates the left ICA stenosis at the bifurcation. The elongated opacification in the upper neck represents contrast squeezed through the 20% residual lumen. The AP cranial view showing brain filling only from the critically stenotic left ICA and indirect collateral circulation is a sobering reminder that the brain can sustain perfusion through remarkably compromised pathways until it can't. Case 2 of ascending and deep cervical collaterals teaches the anatomic distinction that is essential for subclavian angiography interpretation. The ascending cervical artery arises from the thyrocervical trunk, while the deep cervical artery arises from the costocervical trunk, two separate subclavian artery branches. On the lateral view, the ascending cervical is anterior and the deep cervical is posterior, making them readily distinguishable. When both are enlarged as vertebral collaterals, their origins from separate trunks means they are separately addressable. Important information for deciding whether vertebral artery stenting at the origin is feasible or whether the cervical collaterals provide an adequate functional equivalent that makes stenting unnecessary. The pharyngeal branches of the subclavian artery as vertebral collaterals are most impressively demonstrated on the AP view. The lateral view confirms the ascending cervical artery component, but the AP view is necessary to appreciate the full tangle of collateral vessels in the lateral neck. The occipital artery filling retrograde from the vertebral artery is well demonstrated here. The vertebral fills the occipital retrograde, the occipital then fills the external carotid retrograde. This demonstrates the bidirectional relationship between the vertebral and occipital arteries. Flow direction depends entirely on which end has higher pressure. In vertebral stenosis, pressure is higher in the occipital ECA territory than distal to the stenosis, so flow reverses and provides antegrade vertebral supply. Recognize this pattern. Retrograde occipital to vertebral is a reliable indicator of vertebral origin stenosis or occlusion. This 74-year-old with episodic left body numbness triggered by head turning is a classic presentation of hemodynamic insufficiency in multivessel occlusive disease. The right CCA is occluded and the brain is surviving on a complex multivessel collateral relay, tracing the cascade: inferior thyroid artery to superior thyroid to ECA retrograde. ECA fills the ascending pharyngeal neuromeningeal trunk reconstitutes the cavernous ICA. Simultaneously, vertebral to occipital artery flow provides parallel reconstitution of the ECA from the posterior circulation. The neuromeningeal trunk pathway documented here is the anatomic substrate for the classic symptom of burning posterior throat pain during vertebral angiography. Contrast reaching the ascending pharyngeal territory via this anastomosis stimulates pharyngeal sensory branches. The anterior spinal artery route to the basilar artery is the most indirect and least well known of all the extracranial cerebrovascular collaterals. In this case, the left ICA is occluded and the left vertebral artery is irregular. Critically, the left vertebral ends as an isolated pica and does not contribute to the basilar artery. The thyrocervical trunk anterior spinal artery basilar pathway provides the only basilar artery supply available. This route is only detectable on the lateral posterior fossa view during subclavian injection, an unusual projection that most radiologists would not think to obtain. This case is a reminder that complete cerebrovascular assessment in multivessel occlusive disease requires injections of all cervical vessels, including subclavian arteries, and must include posterior fossa projections during subclavian injection when vertebral abnormalities are suspected. Section 3 covers the normal variants of cerebrovascular anatomy that are clinically significant in the context of interventional procedures. These are not rare academic curiosities. Several of them are life-threatening if unrecognized. The persistent trigeminal artery and persistent hypoglossal artery connect the ICA directly to the basilar artery. The persistent stapedial artery creates a pathway from the ICA to the MMA. The aberrant carotid artery in the middle ear is indistinguishable from a glomus tumor on clinical examination, and biopsy is potentially fatal. The fetal PCA variant means that ICA occlusion also eliminates the posterior cerebral artery territory. Each of these variants demands pre-procedural recognition before any carotid skull base or posterior fossa intervention. This complete list of 19 clinically significant variants provides the systematic framework for pre-procedural variant screening. High-risk variants that demand immediate action when identified. Persistent trigeminal artery requires aneurysm and AVM screening. Aberrant petrous carotid requires urgent communication to the referring surgeon before any ear procedure. Persistent stapedial artery changes the approach to any MMA embolization, and fetal PCA origin dramatically expands the risk zone of carotid territory interventions. Medium risk variants that alter planning but don't prohibit intervention. Cavernous ophthalmic origin, carotid loops and posterior meningeal from ECA. Low-risk variants that require documentation but rarely change management. Complete circle of Willis, cervical carotid loops without kinking, and multiple SCAs. Always document variants systematically. Every patient deserves a complete variant inventory before intervention. The persistent trigeminal artery is the most common of the primitive carotid basilar connections, occurring in approximately 0.1-0.2% of the population. It is the remnant of the embryologic trigeminal artery that briefly connects the ICA to the basilar in the 5th week of gestation before the posterior communicating artery develops. Its clinical importance lies in 3 facts. It is associated with a higher incidence of intracranial aneurysms. It creates a direct ICA to basilar shunt that can dramatically complicate ICA territory interventions. And in the case shown here, it sustains a carotid cavernous sinus fistula from the basilar artery side. The 3-image sequence with manual carotid compression is the classic technique for demonstrating posterior circulation flow through a persistent trigeminal artery. Without compression, the ICA pressure masks the retrograde flow. Case 2 of the persistent trigeminal artery shows the classic AP and lateral appearance when the artery is large. The characteristic angiographic feature on the AP view is a diagonal vessel coursing from the cavernous ICA toward the mid-basilar artery. Diagonal because the trigeminal artery courses posterolaterally from its ICA origin to enter the basilar at the level of the upper pons. The vessel tends to opacify the contralateral posterior cerebral artery and superior cerebellar arteries because flow direction follows the basilar artery current toward the distal basilar bifurcation. On the lateral view, the connection appears as an arching vessel connecting the cavernous sinus region to the dorsum sellae clivus region. Any patient with a confirmed persistent trigeminal artery should undergo dedicated posterior fossa MRA to screen for associated posterior circulation aneurysms. The persistent primitive hypoglossal artery is the second most common residual primitive carotid basilar connection, occurring in approximately 0.03% of the population. It is defined by 3 criteria: origin from the cervical ICA at the C2-C3 level, traversal of the hypoglossal canal, and termination at the proximal basilar artery. The ipsilateral vertebral artery is hypoplastic or absent in the majority of cases because the basilar artery was supplied by the hypoglossal artery during fetal development. The AP vertebral view in this case demonstrates the hypoglossal artery coursing medially toward the hypoglossal canal, differentiating it from the C2 muscular branch, which is extradural and courses laterally to the occipital artery. The practical implication: in any patient where the ipsilateral vertebral artery is not visualized during vertebral injection, look for a hypoglossal artery on carotid injection. The persistent stapedial artery is clinically important because it converts the middle meningeal artery, normally an ECA branch, into an ICA branch. This means that in patients with this variant, embolization of the MMA will occlude an ICA branch, not an ECA branch. The CT findings are pathognomonic. Absent or hyperplastic foramen spinosum on bone window CT confirms the diagnosis before angiography because the stapedial artery does not use the foramen spinosum pathway. An enlarged geniculate fossa on temporal bone CT is the second CT sign. On angiography, the diagnostic features are: the MMA fills on ICA injection, the MMA has an unusual course without the normal curve at the foramen spinosum, and the MMA anastomosis with the ophthalmic artery. Always review skull base CT windows before interpreting a vertebral or carotid angiogram. CT bone window can provide the diagnosis before contrast is injected. Case 2 of the persistent stapedial artery reinforces the two key angiographic findings. First, the MMA is visible on internal carotid injection, not external carotid injection. Second, the MMA lacks its characteristic curve at the foramen spinosum because it does not enter the skull base through that foramen. The absent foramen spinosum on CT is the most reliable pre-angiography screening test. Routinely review temporal bone CT windows on all patients before intracranial or skull base angiography. In a patient with an absent foramen spinosum who requires MMA embolization, the procedure is contraindicated via standard ECA approach. An ICA approach with extreme caution for ophthalmic artery protection would be required. This variant, though rare, is encountered regularly enough in a busy interventional practice that it must be in every operator's mental checklist. Cervical ICA loops and coils are among the most commonly encountered variants in routine angiographic practice and also among the most commonly mismanaged. The key teaching point is the distinction between coiling, which is a harmless congenital variant, and kinking, which can cause hemodynamically significant ICA stenosis. The criteria for hemodynamic significance are strict: actual kinking of the vessel with angulation greater than 90 degrees, post-kink or post-stenotic dilation confirming turbulent flow, and angiographic evidence of retardation of contrast flow through the coil. Without all three criteria, the coil is incidental and should not prompt intervention. Patient 2 with bilateral symmetric loops demonstrates the classic congenital pattern. Symmetric bilateral loops at the same cervical level are almost always congenital and rarely hemodynamically significant. The recurrent artery of Heubner is classified as a normal variant because its exact origin point varies, most commonly from A2 but sometimes from A1, as in this case. Its characteristic lateral then medial course along the horizontal ACA and proximal MCA before terminating in the lenticulostriate territory is the key identifying feature on AP angiography. The clinical importance of this vessel is outsized relative to its caliber. It supplies the head of the caudate nucleus, the anterior limb of the internal capsule, and the anterior putamen, territory where infarction causes profound cognitive and motor deficits. The artery of Heubner and the perforating lenticulostriate arteries are the reason that carotid bifurcation and proximal MCA embolization must be performed with extreme caution. Inadvertent occlusion of a lenticulostriate vessel causes immediately apparent neurologic deficit. The anomalous origin of the ophthalmic artery from the middle meningeal artery is the most common anomalous ophthalmic origin and is clinically the most dangerous variant in the context of MMA embolization. In the normal case shown here, the ophthalmic arises from the MMA in a patient with both a frontal meningioma, where the anterior falx artery is enlarged, and a juvenile nasopharyngeal angiofibroma. The critical teaching: when the ophthalmic artery arises from the MMA, any embolization of the MMA for any indication, meningioma, devascularization, dural AVF treatment, epistaxis, will occlude the ophthalmic artery and cause blindness. This is not a risk to be managed. It is a contraindication to MMA embolization via standard ECA approach unless the ophthalmic origin can be protected by superselective catheterization distal to the ophthalmic origin. The aberrant internal carotid artery traversing the middle ear is the most surgically dangerous vascular anomaly in otolaryngology. The presentation is a pulsatile red retrotympanic mass. identical on clinical examination to a glomus jugular or glomus tympanicum tumor. The differential diagnosis from a glomus tumor is critical because biopsy of an aberrant carotid artery results in pulsatile arterial hemorrhage, exsanguination into the middle ear and pharynx, and potentially fatal outcome. The axial CT diagnosis is definitive. Trace the expected course of the carotid canal. It should curve anterolaterally through the petrous bone. An aberrant carotid traverses the middle ear instead of the normal carotid canal. This diagnosis must be made before otoscopy-guided biopsy in any patient with a pulsatile red retrotympanic mass. CT of the temporal bones is mandatory, not optional, before any such procedure. The cavernous origin of the ophthalmic artery is the second most common anomalous ophthalmic origin after the MMA origin. Its location at the inferolateral trunk of the cavernous ICA positions it in the embryologic remnant territory of the dorsal ophthalmic artery, which in fetal life provided orbital supply before the definitive ophthalmic artery established its supraclinoid origin. The clinical relevance is greatest during cavernous sinus surgery, specifically during surgical treatment of cavernous sinus aneurysms or carotid cavernous fistulas, where the inferolateral trunk and its branches may be encountered or sacrificed. If the ophthalmic artery arises from the cavernous ICA at this location, any procedure disrupting the cavernous sinus below the clinoid will threaten ophthalmic flow. Pre-treatment carotid angiography with careful identification of the ophthalmic artery origin is mandatory before cavernous sinus intervention. The fetal origin of the posterior cerebral artery is one of the most important anatomic variants in cerebrovascular surgery planning. Normally, both posterior cerebral arteries arise from the basilar artery bifurcation. In the fetal configuration, the posterior cerebral artery retains its embryologic origin from the ICA, the pattern present in all fetuses before the posterior communicating artery regresses. This variant occurs unilaterally in approximately 20% of the population. The clinical consequence is profound. In a patient with fetal PCA origin, ICA occlusion or sacrifice does not merely eliminate the anterior circulation. It simultaneously eliminates the ipsilateral posterior cerebral artery territory, adding the occipital lobe, thalamus, and midbrain to the territory at risk. The MRA images shown here are particularly useful for pre-operative planning because they demonstrate the variant non-invasively. Every patient considered for ICA test occlusion or planned ICA sacrifice must have pre-procedure imaging of the PCA origins. The ascending pharyngeal artery origin from the cervical ICA is a rare variant that creates diagnostic confusion because the ascending pharyngeal appears on ICA injection rather than ECA injection. The practical problem is that when performing ICA angiography for diagnostic purposes, the ascending pharyngeal filling creates the false impression of an ECA ICA anastomosis. Specifically, it resembles the pattern of an ascending pharyngeal filling retrograde from the neuromeningeal trunk into the ICA, when in fact the flow direction is antegrade from the ICA. Recognition of this variant requires careful evaluation of the flow direction of the ascending pharyngeal on ICA injection. Additionally, if an interventional procedure targets the ICA at the level of the aberrant ascending pharyngeal origin, sacrifice of this vessel would eliminate pharyngeal and posterior pituitary blood supply, the same consequences as ascending pharyngeal artery embolization. The complete circle of Willis is rarer than most physicians assume. Autopsy series consistently find it in only 20 to 21% of cases. The remaining 79% have at least one incomplete segment. This case from a WADA test demonstrates the functional consequence of a complete circle. A single ICA injection fills both anterior circulations, the entire basilar artery, and both posterior cerebral arteries. The clinical utility shown here is direct. The test injection at slow rate filled only the left hemisphere, confirming that the right hemisphere would be safely isolated during sodium amytol injection. A complete circle of Willis provides the most robust protection against focal ischemia in any territory, but does not eliminate the risk from ECA embolization procedures which operate upstream of the circle. Always assess the circle of Willis status before carotid territory interventions. It determines the collateral reserve available if ICA flow is temporarily reduced. Multiple superior cerebellar arteries are one of the most common basilar artery variants, and they create a specific technical challenge for basilar tip aneurysm coiling. The normal anatomy is a single SCA bilaterally at the level of the pontomedullary junction. In this case, there are 2 SCAs on the left and 3 SCAs on the right, all arising from the basilar artery at slightly different levels. During coiling of a basilar tip aneurysm or catheter navigation through the basilar artery, inadvertent occlusion of a duplicate SCA will cause superior cerebellar artery territory infarction, ipsilateral cerebellar ataxia, dysarthria, and ipsilateral Horner syndrome. Always count SCA origins on both AP and lateral vertebral angiograms before any basilar intervention, and document the total number and their relationship to the aneurysm neck. The tortuous basilar artery is a finding that increases in prevalence with age and hypertension, reflecting the same arterial wall changes that cause tortuosity in other vessels. The key angiographic observation is that the basilar swings away from the dominant vertebral, in this case away from the right vertebral. This is because the more forceful flow jet from the dominant vertebral pushes the basilar artery to the contralateral side over time. The clinical significance has 2 dimensions. Diagnostic: tortuous basilar can be mistaken for a basilar aneurysm or dolichoectasia on CTA or MRA, requiring DSA for clarification. And interventional: tortuous basilar increases the technical difficulty of posterior circulation, catheterization, and may require specialized guide catheters or triaxial systems for distal access. Distinguished from dolichoectasia, which also involves vessel wall ectasia, fusiform dilation, and layered thrombus. The isolated pica variant, where the vertebral artery terminates as pica without contributing to the basilar artery, has important implications for posterior fossa angiography quality. If the angiographer selects the smaller hypoplastic vertebral artery for injection and it terminates as an isolated pica, the entire basilar circulation will not be opacified. This is why the standard practice is always to inject the dominant vertebral artery, which can be identified on the arch aortogram or CTA before selective injection. The 0.2% prevalence means that in a practice performing 500 vertebral injections per year, the interventionalist will encounter this variant once per year. The association with aortic arch vertebral origin is important. The left vertebral arising directly from the arch is the most common non-standard vertebral origin and is consistently smaller than the subclavian origin vertebral. The inferior thyroid artery normally arises from the thyrocervical trunk of the subclavian artery. In this variant, reported in up to 0.8% of cases, it arises from the vertebral artery instead. The innominate angiogram clearly shows a normal CCA and subclavian, with the inferior thyroid artery originating from the vertebral rather than the thyrocervical trunk. The clinical significance is specific to vertebral artery interventions. Vertebral artery stenting for stenosis or vertebral artery sacrifice during vertebral aneurysm treatment could inadvertently occlude the inferior thyroid artery origin at the vertebral, compromising thyroid and parathyroid blood supply. Hypothyroidism and hypoparathyroidism following vertebral artery intervention have been reported in the context of this variant. Pre-procedure review of cervical anatomy on CTA is recommended before any vertebral artery intervention. The absent vertebral artery is not truly absent in most cases. The vessel is hypoplastic, terminates early, or has an anomalous origin that was not identified. The complete documentation of possible vertebral artery origins is practically useful. A vertebral artery not seen arising from the subclavian may arise directly from the aortic arch between the common carotid and subclavian or distal to the subclavian. The ascending cervical branch of the thyrocervical trunk, visible in this angiogram as the curvilinear vessel extending cephalad, is the collateral that substitutes for the missing left vertebral. The critical teaching is that the absence of a vertebral artery on subclavian injection does not mean the patient has no vertebral supply. They may have a contralateral dominant vertebral or an anomalously originating vertebral that requires targeted injection to demonstrate. The posterior meningeal artery is an anatomic bridging vessel between the posterior fossa dura and the meningeal circulation. Its anomalous origin from the ECA occipital artery is demonstrated here, a thin vessel coursing along the inner posterior fossa table. The AP versus lateral distinction between anterior falx and posterior meningeal arteries is a classic diagnostic challenge. On the AP view, a thin midline vertical artery could be either. The lateral view resolves the question. Anterior falx arteries run along the anterior inner table, while posterior meningeal arteries run along the posterior inner table. Clinical relevance: posterior meningeal artery hypertrophy is seen with posterior fossadural AVFs, meningiomas of the posterior fossa, and as an additional route for occipital territory anastomosis. Always evaluate both projections before concluding whether a meningeal artery is anterior or posterior. Section 4 addresses the practical technical aspects of maximizing collateral visibility during diagnostic angiography. These techniques are not merely academic. They are the difference between identifying a dangerous anastomosis and missing it. The fundamental insight driving all these techniques is that collateral vessels are low-flow pathways that only become visible when pressure differentials are maximized. A generous contrast bolus increases intraluminal pressure transiently, a hydraulic pressure wave that forces contrast into low-resistance anastomotic channels that would otherwise not fill. Superselective catheterization positions the contrast bolus maximally close to the target anastomosis. Understanding the physiologic factors that open or close collateral channels allows the angiographer to predict which patients will show collaterals and which will not. The left panel DSA injection parameters represent the consensus rates for optimal collateral visualization. The common carotid injection at 6 cc/second for 8 cc total is deliberately higher than the standard diagnostic carotid injection. The extra flow rate and volume increase intraluminal pressure to force contrast into collateral channels. The external carotid hand injection at 3.5 ml is an exception. Too much pressure in the ECA during embolization can actually force embolic agents through anastomotic connections. Controlled hand injection is safer. The right panel factors explain why some patients show collaterals beautifully and others show nothing despite pathological flow. The most practically important factor for routine practice: patients with hydrocephalus or elevated intracranial pressure show ICA collaterals more readily because the high intracranial pressure increases the pressure gradient driving collateral flow from the lower pressure ECA territory. Section 5 presents dedicated case studies that demonstrate ECA ICA anastomosis in complex clinical scenarios. These cases were selected because they each illustrate a specific teaching principle. The MMA basilar case demonstrates that even a vessel appearing to supply only extraaxial structures can have a direct connection to the basilar artery. The encephalodurosynangiosis case shows how post-operative bypass surgery creates new anastomotic patterns that must be managed differently from natural collaterals, and the 3 bypass graft cases demonstrate the angiographic appearances that the interventionalist must be able to recognize in patients who have undergone prior cerebrovascular surgery. In each case, failure to recognize the collateral or anastomotic pattern could result in catastrophic iatrogenic injury. The middle meningeal artery to basilar artery direct connection demonstrated here is one of the rarest and most dangerous anastomoses in the ECA ICA spectrum. In this case, an arteriovenous fistula creates the hemodynamic conditions that make the connection visible. The high-flow AVF acts as a pressure sink that draws contrast from the MMA through the enlarged trigeminal remnant connection into the basilar artery. The critical safety message is unambiguous. The slide states that embolization of this AVF could be fatal, and this is not an exaggeration. Particles or liquid embolic agents placed in the MMA would traverse this connection into the basilar artery, causing basilar artery occlusion and death. This case is the strongest possible argument for obtaining vertebral angiography before embolizing any MMA lesion. Direct MMA basilar connections, while rare, are immediately life-threatening if missed. This case of Moyamoya disease and encephalodurosynangiosis demonstrates the most complex collateral pattern in the course. a post-operative state with multiple simultaneously active collateral roots. The EDAS procedure has placed STA branches against the dura, and over time, hundreds of small collateral vessels have formed between the scalp vasculature and the ischemic cortex. In addition to the surgical collaterals, the markedly enlarged MMA provides ACA supply via the anterior falx artery, demonstrating that when the ICA is occluded, every available meningeal and extracranial vessel will enlarge to meet cortical demand. The warning about stair sacrifice is clinically urgent. In a patient like this, the stair provides the majority of MCA territory supply. Sacrifice of the stair, for example during a tumor resection that crosses the scalp, would be equivalent to performing an MCA territory stroke deliberately. Communication with the neurosurgeon about preserving the stair is mandatory in every moyamoya patient with prior EDAS. The stair MCA bypass is the gold standard surgical treatment for ICA occlusion with hemodynamic insufficiency unresponsive to medical management. In this case, bilateral ICA occlusions are the indication. The surgical anatomy on the lateral angiogram shows the dotted line stair running superficially along the scalp, transitioning to the solid line MCA at the anastomotic site within the craniectomy defect. The end-to-side anastomosis means the stair end is sewn to the side wall of the MCA, preserving distal MCA flow in both directions from the anastomotic point. The retrograde ophthalmic artery filling of the supraclinoid ICA via the anastomosis demonstrates that even after ICA occlusion, intracranial ICA flow can be restored by sufficient bypass graft flow pressure. The angiographer must trace the stay course from its scalp origin through the craniectomy defect to the MCA anastomosis to confirm graft patency. Say MCA bypass case 2 demonstrates the left hemisphere bypass with the anastomotic site clearly marked by the asterisk on AP angiogram. The lateral external carotid angiogram is the optimal view for bypass assessment because it shows the entire stay course from its origin at the superficial temporal fossa through the craniectomy to the cortical anastomosis. The anterior 4 sylvian branches showing good filling confirms that the bypass is providing adequate perfusion to the anterior MCA territory, the most hemodynamically compromised region in ICA occlusion. The teaching note about the stair MCA anastomosis mimicking a natural ECA ICA collateral through the parietal bone is clinically important. In patients who have undergone bypass surgery, every parietal bone traversed by an ECA branch on angiography should be evaluated for a surgical anastomotic site, not assumed to be a natural collateral. The subclavian to common carotid artery saphenous vein bypass graft represents the extracranial solution for proximal CCA occlusion. The intraoperative photograph provides a uniquely direct view of the actual anastomosis. The saphenous vein graft is clearly visible, connecting the right subclavian artery to the right CCA. The list of indications covers the clinical scenarios most commonly encountered. Takayasu's arteritis frequently involves the brachiocephalic trunk with both subclavian and CCA origin occlusion. Post-radiation occlusion is increasingly common as long-term cancer survivors develop radiation arteritis. Subclavian steal syndrome occasionally requires bypass when endovascular treatment is not feasible. Post-procedure follow-up angiography must include the bypass graft as a specific target. Graft stenosis at either anastomosis is common and is the most frequent cause of late graft failure. This case is among the most complex cerebrovascular bypass reconstructions in the surgical literature. The patient has had both CCAs sacrificed or occluded, right CCA for oral fistula, left CCA nearly completely occluded from radiation changes, and the stair was not available because the CCA occlusion eliminated its proximal flow. The two-stage solution placed saphenous vein grafts from the subclavian arteries directly to the distal MCAs bilaterally, bypassing the entire cervical carotid circulation. The lateral graft angiogram showing excellent intracerebral filling is the evidence of technical success. The AP view demonstrating filling of both the ACA group and the lenticulostriate circulation confirms that the graft is providing adequate pressure and flow to supply the deep perforator territory, the critical zone for neurologic function. This case represents the limit of surgical cerebrovascular reconstruction capability. Section 6 consolidates the post-operative bypass graft cases and provides additional angiographic technique notes for the extracranial collateral circulation. This section completes the didactic arc of the course. Having learned the natural anatomy, the natural anastomoses, the anatomic variants, and the angiographic techniques, the learner now needs to understand how surgical interventions alter the vascular landscape and create artificial anastomotic networks that must be treated with the same respect as natural collaterals. The final slides in this section provide a practical reference summary of all bypass graft types and the specific angiographic principles for evaluating the extracranial collateral circulation. This overview of post-operative bypass graft types serves as the reference summary for a busy interventional practice. The common thread running through all 5 bypass categories is the clinical mandate stated in the last 3 bullets. All bypass grafts create artificial ECA ICA or subclavian ICA anastomotic connections. These grafts must be identified and preserved during future procedures, and bypass graft vessels must be included as potential collateral conduits in every angiographic assessment. A practical suggestion for clinical implementation. When reviewing a patient's medical history before a cerebrovascular procedure, always ask about prior bypass surgery, carotid endarterectomy, or head and neck surgery that might have altered the vascular anatomy. If a prior bypass is identified, obtain the original operative report to understand the graft anatomy before proceeding. This final technical note slide consolidates the key angiographic principles for evaluating the extracranial circulation that are most commonly omitted in routine practice. The most important message: subclavian angiography is not optional in patients with multi-vessel occlusive disease. A complete cerebrovascular assessment, one that can genuinely be called complete, must include the subclavian arteries and must obtain lateral posterior fossa views during subclavian injection when vertebral abnormalities are present. The warning about the ascending pharyngeal artery mimicking the string sign of ICA occlusion is a practical patient safety message. Before diagnosing ICA occlusion on angiography, confirm that the vessel you are interpreting as a reconstituted ICA is not actually an enlarged ascending pharyngeal artery filling the cavernous sinus. The two can appear identical on an AP injection. Always obtain oblique views to separate the ICA from the ascending pharyngeal when this distinction is uncertain. This conclusion crystallizes the 6 safety principles that should govern every neurologic interventional procedure. Principle 1, map all ECA ICA anastomosis, is the action-oriented summary of the entire course. Identification is not passive observation, it is active mandatory pre-procedural mapping. Principle 2, the ophthalmic artery is the final common pathway, explains why blindness is the most common serious complication of ECA embolization. 6 separate routes can deliver embolic agents to the ophthalmic artery from the MMA, ADTA, infraorbital, facial angular, stay supraorbital, and stapedial connections. Principle 3, systematic multivessel evaluation including subclavian, prevents the common error of declaring collateral mapping complete after only carotid injections. Principle 4, recognize normal variants, is the life safety message that every practicing interventionalist must internalize. A missed persistent trigeminal artery, a missed aberrant carotid, a missed fetal PCA origin can each result in catastrophic and irreversible neurologic injury. The final principle about bypass grafts acknowledges that the vascular landscape is modified by surgery and must be re-evaluated in every patient with prior cerebrovascular intervention. Thank you for completing this educational course.